Well, good afternoon, everyone, and welcome to MedicAlert's Health Hour Live. We are really glad you're with us today to join us about a talk on diabetes and diabetes in the time of COVID. And what does that actually mean? We have two fabulous guests with us today, joining us from Sunnybrook Health Sciences Center here in Toronto, Dr. Jeremy Gilbert and Dr. Ilana Halperin. Welcome to you both. We're really excited to have you here to answer the questions from our audience. We've had more than 400 people sign up for this webinar, so that tells you the level of interest that we have relative to type 2 diabetes in the time of COVID. And what does that mean with virtual care? There's lots of questions that always are emerging. I'm sure you have them in your practice on a daily basis. But I think the key thing really is to get a handle on what are we looking at? What are the questions that people have? But before we get rolling, one of the things that I would like to do is to say thank you to our partner, Diabetes Canada, and the tremendous amount of work that they have done in preparation with us for this particular webinar. Thank you in particular to my very good friend, longtime friend, Diabetes Canada President and CEO Laura Siren, for her help and support. And thank you, Dr. Gilbert and Dr. Halperin, for joining us today. One of the things that I think that's also really important for us to share is a campaign that Diabetes Canada has recently launched, a new year-long campaign called "We Can't Wait Another 100 Years." This is the 100th year of the celebration of insulin, and unfortunately, diabetes is still a successful disease, and it sounds strange to describe it as a successful disease. But even with the advent of insulin, which was discovered 100 years ago, diabetes is still successful at taking lives. So one of the things we want to be sure to do is to make sure that people are armed with the right information. So today, that's what we're looking to do, at least in the hour that we have today, is to arm people with the information that they need in order to be able to take care of themselves in a time where they may not necessarily have access to physicians in the way that they've had access in the past. So welcome, Dr. Gilbert and Dr. Halperin. Happy to have you here today.
Thanks for having us.
Thanks, Leslie. Thanks for having us.
Welcome. So one of the things I wanted to open, and maybe we'll start with you, Jeremy, is really how does the pandemic affect those living with diabetes or type 2 diabetes? What have you seen in the last year?
Yeah, no, it's a great question, Leslie. I mean, it's an all-encompassing question, is it not?
Yes.
I mean, it's really, who has this pandemic not affected in the world? It really has affected everybody. And I think for those people with type 2 diabetes, there's different ways of answering this question. I think, first of all, acknowledging the stress and anxiety and the mental health and wellness independent of the type 2 diabetes, but recognizing that that can certainly impact on the type 2 diabetes as well. There's emotional eating, gyms are closed, and people's opportunities to do the right things from a lifestyle modification perspective is sometimes challenged due to the pandemic. And even within their own living environment, financial strains, anxiety of what will be with this pandemic has added undue stress that can affect the sugars as well. Even access to medications, there was shortages, the pharmacies giving out more or less medications. I think all of that has affected us. And then even just getting blood work and seeing physicians, and Dr. Halperin is one of my colleagues, has been a champion in terms of the virtual care. And she and I have both working at Sunnybrook had done a lot of work on virtual care and seeing people. We have advantages of people sharing their sugars remotely now, and some of those platforms have been great. But I think certainly on a day-to-day basis, there's no doubt that the pandemic has had significant effects. I should also add that people with type 2 diabetes are at the same risk of getting COVID as people without type 2 diabetes, but should they get COVID, often have a more sinister course, more likely to require hospitalization or ICU, which puts a higher degree of fear and anxiety in people living with type 2 diabetes and their families.
So I think that's a great sort of segue to our next question that many people have posed, which is really, Ilana, what are the risks for those living with type 2 diabetes? What are the risks of getting COVID? Are they different than me, for example?
Yeah, so as Jeremy stated, it's not that people who have type 2 diabetes are at higher risk for getting COVID. If you have someone with and without diabetes in the same environment where there's COVID in the environment, and you spend more than 5 or 10 minutes in an unmasked way with another individual, then the chance of getting COVID is quite high. And it seems to be increasing with some of the newer variants that we're seeing that are extremely contagious in the last few weeks. However, somebody who doesn't have diabetes may have a milder course of illness. And so we certainly know that people who have higher blood sugars will have a harder time fighting the inflammatory response that's associated with getting COVID. And a lot of our patients with type 2 diabetes have comorbid conditions. So obesity is a big risk factor for having worse outcomes when it comes to the breathing, needing more oxygenation, potentially needing intensive care for higher levels of care, and even intubation and ventilation. People with pre-existing heart disease and the older age, all of those things cluster with type 2 diabetes. And a lot of patients who have COVID see that their blood sugars get very high because as the body's fighting off the infection, they have higher rates. Just the body responding to inflammation causes the numbers to go up. And so those are the reasons why we want patients with type 2 diabetes to ideally take public health measures that much more seriously. And I think there will probably be a question about this coming up, but we'll take the opportunity to advocate that patients with diabetes should be front of the line in terms of community members getting access to a vaccine. But I think the key message is you're not at higher risk of getting it, but you're at higher risk of getting sick if you get it.
So, which is really, it's a scary thought for those living with diabetes that the risk is, or the risk isn't any different, but the impact is significantly higher.
Yeah, and that's actually something that I was going to piggyback on Jeremy's response. A lot of work I had to do in the first part of the pandemic, which really is frustrating work for physicians, but we do it because it's being asked of us, is writing notes for employers. Writing notes for employers that this person has a medical condition that increases their risk from getting more sick should they get should they get the virus, and different employers and people responding differently. We know it's been a big political thing across the country, but especially in Ontario around paid sick days, and a lot of people with diabetes are in these vulnerable frontline working environments and can't afford to take time off, and that's a very scary situation for them, and we do what we can to advocate.
So when we're talking, go ahead, Jeremy, please.
Yeah, Leslie, I was just going to add to something that Ilana was saying, that because of COVID and everything that's going on, it's kind of like the health condition that everybody has at the forefront of their brain right now. And I think since March of 2020, when this pandemic began, the diabetes sometimes took a bit of the back burner. But I think now that we're recognizing that higher sugar values and poorer control can actually lead to a worse course of diabetes, is actually a call to action for all the people who are listening, that this is an opportunity to actually work with your healthcare providers to try and get the diabetes better controlled now, because if one should develop and get COVID, then at least the sugars are controlled, which leads to a better outcome. So this is actually, we can leverage the COVID-19 to kind of appreciate the value of getting the diabetes controlled.
So that's a great segue to my next question, which is literally related to how often should people be seeing their physician who manages their diabetes in the time of COVID? Does it need to change? Does it look different? Jeremy, talk a little bit about what that should be from your perspective.
So I think that this question must be very individualized and should be discussed with, and it's not only the physician, but really the whole diabetes care team. So the diabetes nurse, the dietitian, the pharmacist, whoever's involved in the team. And sometimes we actually still do need to see the person come in and it can't be virtual, but the vast majority of the time it can be virtual. And again, with better platforms, with electronic medical records and ability to share glucoses online and so forth, this has made it a little bit easier to work with people virtually. I think for people who are more well controlled, it may not be as necessary to visit with them as often, but for people who do need more attention, there's no reason why it can't be done more often. And I think typical visits most of the time are in that 3 months, 6 month range, understanding that sometimes it needs to be more often than 3 months, and sometimes it can be pushed off later than 6 months. Again, that should be individualized. But the point being that virtual care can still offer advantages, and an appointment can still be effective. And I think in addition to being the discussion about how often virtually, is also in terms of the appointments, but also how often should blood work be done, and that whole kind of aspect of diabetes care.
Just
Ilana,
to follow, just to follow up on that, the College of Family Physicians of Canada, I believe, along with Diabetes Canada, did issue some guidance in April that recommended that there still be a touch point every 3 months for those whose A1Cs are not a target. So looking at glycemic control as sort of helping you make that individualization. And that ideally everyone should still be seen at least once annually for an in-person physical examination, which is a bit frightening because we are sort of staring down that 1 year mark now. And I was speaking to Leslie offline before we started, and I said, you know, in the spring, I was happy to tell people to defer their blood work. I really encouraged everyone to get blood work in the summer when the case counts were lower because we were worried about a second wave, and now the second wave is worse than the first. And I don't really want to tell my patients to come in the next 6 to 8 weeks, even though we're now looking at some of them not having been seen in person for a year. But there are a lot of great tools available to help make your virtual care appointments more useful, including home blood pressure monitoring. There's some validated tools on the Diabetes Canada website about how to check your own feet, things that people can do so that they can come prepared to the meeting, and as Jeremy alluded to, monitoring your glucose if appropriate ahead of time.
So you anticipated actually a question I was going to ask you, Ilana, which is really about, because coming to a virtual appointment is very different than coming to an in-person appointment. So how would you recommend people prepare? You talked a little bit about some of the tools that were available through Diabetes Canada, and other things that are available to people to make sure that they're monitoring their condition effectively. But if you were to give maybe and I'm putting you a bit on the spot here, but a top 5 list of
Sure.
what you would want your patients to come prepared to have a conversation with you, what would those be?
I definitely think that virtual care has shifted a lot of the onus on the pre and post appointment time. Just, you know, a lot more work for our admin assistants. So a shout out to our amazing admin assistants who help make virtual care work properly, and to the patients who take the time to get themselves organized. But a lot of things are similar. We want to know what medications you're on. And it's ideal if you have them in front of you and not in the washroom, so that you don't have to run away and get them and come back while we're waiting and we have other patients waiting. We want to know how things are going with your lifestyle and whether you've been keeping track of anything in terms of diet logs or physical activity logs. Have those ready. If you are instructed to monitor your blood glucose, if you can get that into a nice, easy to look at chart, and there are many great mobile applications that come along with blood glucose monitors now that make it really easy to share your data with your healthcare team. And so if you can share your data ahead of time, whether that's through an email or another secure portal, that really helps as well. And then home blood pressure monitoring is important. And in fact, all the time, even before COVID, we'd have patients whose blood pressures were high in our office, but okay at home because coming to the hospital is stressful. So now we can trust those home blood pressure monitors. Having a list of your questions and concerns prepared so that we can have an efficient visit that focuses on what it is that you want to focus on. And again, I think the decision about blood work does need to be individualized depending on what other complications of diabetes you may have, how closely we need to be monitoring things. People who are using continuous glucose monitoring devices regularly, like the Freestyle Libre or the Dexcom device, we can get an estimated A1C quite nicely. So we may be able to defer that blood test. But if somebody has chronic kidney disease with borderline potassium levels, we don't want to defer those. That needs to be checked regularly. So you have to make those individualized decisions about when to go to the lab.
So, and that's where virtual care becomes so important as we navigate the pandemic, and you don't necessarily have the access to physicians that you would have had. I can anticipate, however, Jeremy, that there are fewer questions now, a year into the pandemic, than this one, our next question, which was a big one that most people asked, is what role will vaccines play? Obviously, for people with type 2 diabetes. And the bigger question is, are they safe?
Yes, I mean, the vaccines, it's interesting, like you're saying, Leslie, how the line of questioning has changed, right? In March and April, May, that was not the question. The question then is, what do I need to do at work, as Ilana was saying, and safety and family and isolation and masks. And now the question is about the vaccines. And a lot of this, the questions that we're getting, unfortunately, we don't really have the answers for our patients yet, because we're not really, as physicians, in control necessarily of the vaccine distribution. This is beyond our pay grade and talents. So I think what we can say is that in the vaccine trials that have been done with Pfizer, Moderna, et cetera, there has been people with type 2 diabetes and less so people with type 1 diabetes. And in those subgroups where the people with diabetes were analyzed, the vaccine was equally effective and safe as those without diabetes. So I think, if nothing else, that's reassuring. Recently, in the last few weeks, Diabetes Canada, which you gave a shout out initially and certainly deserves that shout out, Alice Chang and her group put a document together saying that the Diabetes Canada's position is that people with diabetes should get the vaccine. And certainly, Ilana and I have discussed this, though we really feel that they should be ahead of the game and ahead of the line as somebody who we know can have a worse course. But unfortunately, we don't have the control to necessarily dictate when, where, how, all of those questions. So I know people are anxious for those answers, but we just don't have those answers at this time.
Well, Anna, how challenging is it for you as a physician to actually say, I don't have control, I don't have the answers, I hear you. It can't be easy because that's not usually the case.
Yeah, it's very challenging. A lot of things about this pandemic have been very challenging and demoralizing for physicians. Our job is to advocate, and so we do, and we try to advocate. And Jeremy's example of our colleague Alice Chang in Diabetes Canada advocating on behalf of people living with diabetes to say this is an important chronic condition group that should be considered. The Ministry of Health in Ontario did put out a sort of phase 2 plan that's quite vague, and they labeled the term chronic conditions as a reason to, have people get vaccinated sooner. But the devil's in the details, as we well know, and we've seen in the news in the last few days, shortages and cancellations of doses for healthcare providers and frontline people. So we are still, unfortunately, a ways away from community members who aren't in the healthcare sector getting vaccinated. But certainly for the few patients that I have who are healthcare workers and have diabetes, I've strongly advocated for them to get the vaccine. And the few that have had the vaccine for their first dose tolerated it very well without any concerns. One person told me their blood sugars were better.
Well,
so for 48 hours after the vaccine, it was like I didn't have diabetes. Now, I don't know if that's been reproduced in any studies, But my answer to most people, as Jeremy has said, is I don't have control. I will continue to advocate. If given the opportunity to be the one to disseminate the vaccine to my patients, I certainly will be doing that. I doubt that will be the case. I'm sure it's going to be at a much larger scale, like in arenas and convention centers. And the fact that you have diabetes or that you're, 60 is going to be not really taken into account because it'll happen quickly, eventually, for everybody in the spring, summer. But yeah, it's tough. But I recommend everybody get the vaccine.
Thing is, as demoralizing as it is for us as healthcare providers, we really are empathetic to the people living with diabetes and their families and the stress they're going through. And I think, as I said initially, this is a challenge for each and every one of us. And Leslie, your pointed question there about how does it make you feel when you can't respond with a definitive act, I really think one of the things that physicians need to know and to say is to say in the right context, I don't know, and to let people know that. And it's okay not to know and not to have all the answers. Certainly when this came out and what was to be, we didn't know. And we're supposed to be healthcare providers and know the answers, but it's okay not to know. I think it's more important to be honest and upfront with our patients and to say, listen, it's a great question. I don't have the answer. I don't know. I'll see if I can do some searching and get back to you. And sometimes we may not find an answer, but that's okay. I just wanted to throw that out there that's a fine response.
Well, and I couldn't agree with you more. I mean, it is a novel virus. We don't know that much about it. We're learning as we go. And that actually leads me to my next question, which is really about people, diabetes doesn't stop because a pandemic has arrived. There's no sort of pause button that happens. And so some people are asking, well, I'm newly diagnosed with type 2 diabetes. Normally I would be able to go to my physician or my GP or maybe I've been referred, but now I've got this big blocker here and I'm drowning in information and I'm trying to navigate all of this. So how do you help people who are newly diagnosed, who are just beginning to learn how to manage and cope with managing their sugar levels or new technologies or new kinds of eating habits that they may not necessarily have had to deal with in the past? So Ilana, what kinds of things would you say to somebody who's putting up their hand and saying help?
So I hope that anyone who's listening who feels that way knows that there is lots of support. And again, a big shout out to Diabetes Canada, who has a wealth of information on their website. And a big shout out to diabetes educators. Everybody who's newly diagnosed with diabetes should be sent to a diabetes education center. And I know our diabetes education center has successfully converted to doing classes on Zoom, just like this, but in smaller groups so that people can type in the chat and unmute themselves and ask questions. And I actually think it is a lot of information to digest when you're first diagnosed with diabetes, and maybe virtual actually could be better because you could do less intense, more frequent education sessions than, taking half a day off of work to go and meet a nurse and a dietitian in a group setting and learn all about diabetes, which a lot of times people just, they walk away and they've only retained about 10% of the information that was provided to them. But there is no chronic condition that is more in the hands of the person living with it than diabetes. And so at the cornerstone is lifestyle modification. And whether it's a pandemic or not, you do need help, but there are still lots of ways to access those resources virtually. And doctors are open. They're just going to triage who they need to see in person. And so I do hope that you are able to speak on the phone and get personalized advice from your own physicians and referrals. Jeremy and I have continued to receive new referrals throughout the entire pandemic. We take a virtual first approach. We always have the first appointment virtually. And then if there's something that we hear about while we're talking to the patient that makes us think we really need to see them in person, then we put on our mask and our face shield and we bring out our Clorox and we see the patient in person. So it's really important that people not avoid care or delay care for non-COVID related conditions during this very prolonged pandemic, because we are seeing the fallout of that with people showing up in the emergency department with complications of their diabetes and heart disease and stroke and undiagnosed cancers and the like. So care needs to continue. It just has a bit of a different flavor than it did before the pandemic.
That's a great segue to my next question, which is really about what about people who think they might be experiencing symptoms but don't really know? And you know, and we know that there's an end in sight to the pandemic, but when and how much and how definitive that is still up in the air, as you were alluding to before. So the question that we're getting asked, especially because type 2 diabetes is a challenging diagnosis for people to start. Sometimes it takes a long time to figure out the things that are happening to you because you might not recognize some of the symptoms. But how can people be certain if they can't visit their doctor? What about getting an A1C test during the pandemic? What does that look like? What extra precautions do you take? Jeremy, how do you kind of advise people who are sort of on the cusp of, I'm not necessarily sure, but I'm worried if I leave it too long, I may get in trouble?
Yeah, it's a good question, Leslie. I mean, I think a few points here. So first of all, the condition of diabetes is somewhat challenging because often it's asymptomatic, meaning that people don't necessarily have any symptoms at all. So they may feel totally fine, yet have high sugars. And that can be very difficult because they feel well, yet their insides, there's a lot of physiological things going wrong. In terms of the typical symptoms people experience with high sugars and diabetes, classically, they may have some blurry vision or headaches, fatigue. They might feel thirsty or urinating more often. But some of these symptoms are pretty vague. A headache and feeling tired and blurry vision is not necessarily clearly indicative of diabetes at all. This is not a condition that can be diagnosed by the way you feel, or by history, or by physical exam. The only way to diagnose this is through lab work. It is the only way. And the good news is that many of our community and hospital labs have set up a lot of protocols to keep people very safe from a COVID perspective. They understand that people are going to the lab, often are going to the lab because they have medical issues and therefore at high risk. And so they have a lot of protocols in place. They have appointment booking times and social distancing and mask wearing and so forth. So I think people need to be reassured that if blood work is in fact needed, that it should not be avoided. Ilana was talking about the potassium in the kidney, whether that be that or other things, that if a person is really needing, is the recommendation to get blood work done, that people should not be hesitant to go to the labs and to follow all the public health measures to do this as safely as possible. I know on the previous question we had mentioned about that information. I just wanted to shout out also to that people need to be careful with what they read on the internet. And so it is very important, as Ilana was saying, that they do see that Diabetes Education Center to make sure that the correct information is being sent and not misinformation. And I think this leads to this question about the diagnosis, and certainly an A1C is valuable, or a fasting blood sugar. An A1C doesn't need to be done fasting, so it really can be done at any time of the day. A fasting sugar obviously needs to be done fasting, and some of those appointments are more challenging to get. But I think as long as the public health precautions are kept and done, then I think people should go and do that blood work if it's recommended.
So really what I hear you saying is don't be afraid. There are all the right steps in place, and your health is the most important piece of this, and delaying is not necessarily something that people should do.
That's well said, Leslie. I mean, I think that what I have seen is I have a few of my patients who are very fearful of getting blood work, who have underlying kidney and heart disease, and I can't continue to prescribe medication safely when I don't know how they're doing. And so perhaps by being so fearful of the COVID, it's led to this kind of imbalance of ignoring other chronic medical conditions, for which, you know, MedicAlert is very, very familiar since you manage all of these different chronic conditions. And I think that that's kind of that imbalance that we're perceiving. You know, you see these commercials by the government of Ontario, stay home, unless you need to go to the pharmacy or you're going to the doctor or whatever, because the government is recognizing, listen, we can't have people staying home and ignoring their underlying health conditions, because that could lead to worsening of their underlying conditions.
And so true. And as much as we encourage folks living with diabetes to be MedicAlert subscribers in case they ever are in a position where they maybe find themselves in a diabetic coma and they can't articulate what their needs are, those are particularly important. But we really don't want people to get there. So that's a leads to my next my lifestyle question, which is coming up next, which is around. So many of us are working at home, and I can turn, even though I have a lovely background here, I'm about 10 steps to my refrigerator. There are lots of really good things in that refrigerator, but I have to be truthful and honest and say there are some other things that aren't so good when you're managing blood sugars. So Ilana, how do you help people deal with the fact that, you know, at work it's easier? You may not have a kitchen at work. You may not have access to things at work. Your stress levels are certainly different in the time of COVID, and people stress eat. And I've been known to dip into things that I wouldn't normally dip into, because we're all managing in a way that we're trying to get through something that we've never experienced before. But how do you help people to manage those things where they need to satisfy those urges or that comfort, but still maintain proper blood sugar levels?
It's such an important question, Leslie, and I think everybody, whether or not you live with diabetes, is struggling with, you know, this. People are saying they were in the spring, we were joking a lot about gaining the COVID-15, right, or 19. Sorry, 15's freshman, so gaining the COVID-19. But I think, you know, in the first 4 to 6 weeks of the pandemic, I cut everybody like a lot of slack, including myself. Everybody was eating a lot more poorly, drinking a lot more to manage stress and things like that. And then sometime in the middle to the end of April, we sort of said, this is not going away. Like, this was not a 2-week after March break and then everything will be back to normal situation. And you realize that you have to continue to stay on your path towards healthy choices. And so sometimes the best way to manage this is to not have these foods in the house in the first place, and to take the time to meal plan and plan snacks that are satisfying but don't necessarily raise your blood sugars in the same way. So instead of going for the chips, maybe going for some nuts, you know, choosing fruit as opposed to fruit juices. There are things that will, you know, not raise your blood sugars nearly as much because of the content of them. And this is really where a registered dietitian can give a lot more useful advice than I can. But it takes a little bit of you know, trial and error to figure out what are those things that you like to eat that can satisfy your cravings. But sometimes it's about thinking about, what am I feeding? Am I truly feeding hunger, or am I feeding something else? And the other thing that's not happening is we're not spending time commuting, which may have been downtime. And so sometimes people are going right from their bed to their desk, to the fridge, to their desk, to their bed. And they're actually putting in more hours, and they're not taking care of themselves. So a big piece of advice I've been giving my patients is the time that you previously would have spent commuting is not more work time. It should be more self-care time. It should be time where you turn on an exercise video, a yoga video, you read a book. Don't look at the news and doom scroll on Twitter. These things are just making us more stressed out and more likely to reach for those less healthy food choices. But instead of, you know, feeding that hunger, which is also really feeding anxiety that everybody's experiencing in the context of a really tumultuous time, both from the pandemic and a lot of other political upheaval and stressful things happening around the world, is to think about taking time to look after yourself and connecting with people, even if you can't be with them physically, connecting, you know, in a virtual way. And so those are the kinds of messages and time that I've spent speaking with lots of my patients about as well.
Great. So all great advice. We could probably spend a full hour in and of itself on discussing all of those kinds of lifestyle choices. What about people who are really struggling with their sugars and they're really fluctuating? I'm sure, Jeremy, you've seen individuals in your practice where their sugars were under control when they were able to see you on a regular basis in person, and they just had that comfort level of working with an endocrinologist regularly. And you were to virtual appointments, but they're just not working as effectively as they should. And this is a question that we've had from several people who are on our call today. So are there suggestions that you have to be able to help people navigate some of the complexities of managing their sugars that were under control before?
Yeah, so I mean, I think it's a pointed question and it's a real question. I think this is a probably multiple times per day question that I face. Um, I think, first of all, that I would encourage people who are experiencing variability in their sugars and poor control to reach out to their diabetes care team. Just because it's a virtual appointment doesn't mean that help is not there. We've discussed over the last half hour or so all these different ways of using a virtual visit to gain information and therefore can improve management. I think we must acknowledge that the COVID pandemic has changed. We talked just a moment ago about diet. We talked about exercise with gyms being closed, the weather getting colder, access to medications, financial barriers, stress. And we appreciate that sugars are not simply related to one thing. It's not just diet or medications or exercise. There's over like 40 different things that can contribute to any one given sugar reading. There's the weather, there's so many different things, right? So I think we first need to acknowledge and accept the fact that the sugars are variable and say that that's okay. Then what I like to do is kind of work with the person who has diabetes to explore with them on an individual basis why that may be the case. Because why it may be in person A is totally not why it might be in person B. And apples and oranges. So we have to really understand where that person is coming from. Ilana had talked a little bit about in the virtual visit some of the questions she asks, their medications, their blood pressure, but also pointedly said, you know, how are you doing? How are you coping? What's going on in your life? And that actually can give me a lot of information as to why the sugars might be variable. Their sleep is disturbed. They're on shift work. They're stressed. They're emotionally eating. They can't afford their insulin. Whatever the issue is, we can then tackle that. But if we don't know what is contributing to that variability, it's really hard to understand. And so I think that's what I would just say is that we probably first acknowledge that this is going on and then try to work together to come up with some solutions that are mutually agreeable.
So a little bit of a different kind of root cause analysis question that you're asking. And I see, Ilana, you're nodding and smiling. So sort of, there are those who have been diagnosed with type 2 diabetes, but there are those who are in the prediabetes category, who are also challenged by these things, but they may not have an endocrinologist that they're working with because they're pre-diabetic. And the whole goal is to make sure that they don't actually tip over into type 2 diabetes. So if you were to give Ilana your top 3 recommendation for people who are living with in the prediabetes group, what would you say to them as they're navigating all of these things in a regular environment?
I'm really glad you gave me that question because one of the things that I actually do a lot of is care for women with gestational diabetes. And I just this week had our monthly postpartum class. And what we do in that class, it used to be in person and now it's virtual, is about 6 months after women deliver, having had gestational diabetes, they repeat some blood tests to see if they have any signs of ongoing insulin problems. And about 20% of them actually have prediabetes. And the things that I say to them, because you look around the room and they don't all look the same. We see people for various shapes, sizes, ages, races. And some people can say, look, I haven't lost any of my baby weight and I've been eating like crap and I haven't moved and my sugars are normal. And then there's another woman who says I'm doing everything right and my sugars are abnormal and I don't know what else to do. And so I think it's important to recognize the genetic component of diabetes and that not everything is under your control, but there are some things that you can control. And so now I'll talk about those things. But I do have a lot of patients who have slightly higher A1Cs that stay that way. And if you can manage it with good efforts at lifestyle, you know, that you're doing your job. And the prediabetes, people can kind of come in and out of it, an A1C of 5.8, an A1C of 6.2, back and forth. That's okay. You know, the risk of complications is exceedingly low at that point. And some people will always sort of have that bit of prediabetes because that's their genetic predisposition. But what I would say is the most important is the same things I say to those women, even if they have normal blood sugars, because just having had gestational diabetes is in and of itself a big kind of risk factor for the development of type 2 long-term, even if your sugars are normal at 6 months postpartum, is that it's not about a diet. A diet is temporary. It's not about a new 30-day exercise regimen. I'm going to go and walk, 20,000 steps a day for, a month to work, to, get some rewards on my PC Health app or something like that. It's really about a mindset shift and making eating real whole foods that you eat together as a family and physical activity part of your routine and part of your life, because you will need to continue to do it for the rest of your life. You can't do it for a bit and then go back. And so a lot of people focus a lot on the carbohydrate content of their foods. And I think there is lots to be gained about understanding different macronutrients, carbs, proteins, fat. Meeting with a registered dietitian, they are within the diabetes education centers around the country, are mandated to help people with prediabetes have a better understanding of the relationship between food, weight, and blood sugars. But I think it's the three things I would focus on for prediabetes, if we were going to do top 3 recommendations, is mental wellness, physical activity, and healthy eating. And it sounds kind of trite because it's true for everything, but it's extremely important in the context of diabetes prevention.
Absolutely. And the old phrase, it's easier said than done. It is work. It is absolutely.
It's hard work.
It's hard work to do.
Leslie, I think my top 3, and the way when I heard this question, I was like, I wonder if Leslie's going to ask me or Ilana first for this.
Yeah.
Because for sure, absolutely everything that Ilana said is true, but that's the beauty of the question, is what's your top 3? So I kind of lumped all of those recommendations under lifestyle. So whether that be, as Ilana said, not focusing on a particular diet or a particular exercise regimen, but a whole lifestyle kind of shift, exactly. But also to ensure that these people with prediabetes get adequate repeat screening, because although they don't have diabetes now, we know that people with prediabetes are at high risk of developing overt diabetes. So it would be important that a screening plan is put into place. And sometimes these people may benefit from being on certain medications to help lower their sugars. Although I would say that the lifestyle modification is more important than medications, there is evidence as well for that too. So I think those would be my top 3: lifestyle, medications, and screening. And then within lifestyle, I would go with Ilana's approach and categorization.
All really good advice. So take all 6 is really what you're saying in the mix of things.
Very good.
A bit more serious question for you now is really around diabetic neuropathy, a real challenge for those living with type 2 diabetes. This is a question that I'm sure you get asked on a regular basis. It's a tough complication that you're dealing with. And the question that people have, and I would have it too, I don't know the answer to this, is about, can any damage that happens, can it be reversed? And what can people do to check their feet at home? Jeremy, let's start with you, and Ilana, if you want to add. Always happy to hear both perspectives.
Yeah, no, a very important question. First of all, to understand that diabetic neuropathy is probably the most common complication of diabetes. So given that, well, let's say about 1 in 10 people in the province have diabetes, and about half are going to have diabetic neuropathy or more, this is an extremely common problem. The common kind of signs that people might experience if I was to ask screening kind of questions for diabetic neuropathy would be tingling or paresthesias, as we call it, burning sensation, maybe lack of sensation in the feet. Not all of the time is that in fact due to diabetes, because there are other causes of neuropathy that can happen, like sciatica and spinal nerve issues and spinal stenosis. But certainly for people who have longer standing diabetes and for people who have higher sugars, they are at higher risk for diabetic neuropathy. And the nerves dislike when sugars are very high. So the question, can any damage be reversed by diet and exercise? I would say that diet and exercise are modalities to help lower sugars, as is diabetes medications and insulin. And better sugar control is one of the best ways of addressing diabetic neuropathy. Along with recognizing that neuropathy and vascular issues in the feet combine together to cause even more problems, healthy lifestyle with lack of smoking, for example, is really also an important tenet to good diabetic neuropathy care. Diabetes Canada has information for healthcare providers and for patients about proper foot care. And I think highlighting the realities of virtual care, where I simply cannot be seeing everybody's feet visit to visit like we typically did. I think if at high risk, it should be checked every visit, but at a minimum once a year by diabetes care teams. I think having people monitor their feet at home is extremely important, and to alert their healthcare provider should they see ulcers or skin breakdown, signs of infection, redness, warmth, etc. I think ensuring people's feet are not dry is a simple intervention, with making sure it's well lotioned on a regular basis is something that can be done. But what we're looking for is lack of sensation and pain, some of the symptoms that people may experience. We know that the pain medications that we use to treat diabetic neuropathy are not expected to work 100%. People hope that when they have diabetic neuropathy and we use certain medications to help with that, the goal is just to reduce the discomfort by only about 30%. That's the reality. So people need to appreciate those expectations. This is a challenging condition, a condition that leads to significant morbidity, affects people's ability to live properly, to walk daily, to do the exercise that we're recommending, and to go to school and to work. So certainly a great question that you asked, Leslie. And you know, I know it was a bit of a longer answer, but there's a lot of components to this. And Ilana, I don't know if you have anything else to share.
I agree with everything that you've said. I know, again, to reference that CCFP guidance, there's something called the Touch the Toes test, which was actually a UK, United Kingdom diabetes assessment. And you do need somebody, it's hard if you live alone. But if you're living with somebody, they can do a sensory check for you that has been validated against the types of sensory checks that we would do in the office. And so it helps to sort of say, you know, you touch the toes in so many different places and you score it, and this can be found online. And then if you are scoring that you're missing sensation, then that would be a very useful piece of information to provide to your care team, because that might be a reason to bring you in. But for sure, just checking the bottom of the feet, keeping things well moisturized, because dry skin leads to cracks, leads to ulcers and infections. And anything that looks a little bit funny, there should be no delays in care there. That needs to be seen in person, not necessarily by people like Jeremy and I, but we can facilitate getting you to a wound care specialist, a chiropodist, a vascular surgeon, etc., to make sure that ulcers are managed in a timely fashion.
So it really is, and we've talked a lot about the care team. It is really a disease that is managed by a team of individuals with very specific expertise. And to your point around this, there's a reason why there are adages, and the old adage is an ounce of prevention is worth a pound of cure. And that certainly is the case in terms of the kinds of things you've talked about with respect to diabetic neuropathy. We've talked a lot about sort of lifestyle challenges, and probably one of the hardest things for people, we'll spend a little bit of time before we get to our last couple of questions in the hour, because we're coming up on the hour, is with respect to exercise. I have the good fortune of having space where I am, and I've added to my home gym, as many people have over the course of COVID. But there are people who can't do that, and people who are limited or may have limited mobility because they might have diabetic neuropathy. So, it compounds over time. So when people can't get out and get the regular exercise that you would typically see and recommend to your patients, are there other things that people can be doing from an exercise regimen, Ilana, that would help them to be able to kind of navigate this particular?
Yeah, so I mean, I do think even with the most recent stay-at-home order here in Ontario, exercise is a reason to leave your home. And so we've actually been blessed with quite a mild January. I do still encourage people to walk. I think you have to think about where you live and how busy it is and how appropriate that is. But the fresh air can also do wonders for your mental wellness as well. So people should get outside. They just have to get outside in a safe way. And, like for my family, that meant driving 45 minutes north of the city on the weekend to go for a hike where we only came across 2 or 3 other families the whole time we were walking. And it was brilliant. But there are things you can do in your own space. There are tons and tons of free exercise types of videos available online. There's also some useful tools on the Diabetes Canada website, and you don't need fancy equipment in order to move your body. Resistance bands is something that's very easy to get off the, order online, that can help to, even if you don't have a whole set of weights, there's resistant bands exercise. Our colleague, Ron Siegel in Calgary has done a ton of work on exercise and type 2 diabetes, and a lot of great resources on the Diabetes Canada website that can help you. I know there are a lot of people with type 2 diabetes who struggle with arthritis, and the pool was the best place to be when you have arthritis. And that is no question, everybody's missing that, and I don't have a great solution for that. But there are ways to move your body even inside your house. Yoga, restorative yoga, all of those things can help. And so a lot of content online. Again, the world is virtual right now. Lots of gyms, the YMCA, they're running programs virtually. It's not the same, but it is better than just sitting on your couch all day. So those are some of my recommendations.
I'd agree with those. Aerobics are great. You don't need a lot of space for that. Just a mat and you're good to go. And I think it's being creative. Stairs for people who can do that, that's helpful. Walking, if you're in an apartment block, walking along the hallway where there's not people. So I think the outdoors was a good point. What I think the main thing is, though, that COVID, the weather, these cannot be, and I hate to use the term, excuses for lack of exercise. Sometimes people just kind of use that as a crutch. And I think it's really important that we say, listen, we live in Canada, the weather's not good 6 months of the year. This is the fact. But what can we do? I think your point, Leslie, about, home gyms is a very interesting thing, but the reality is to get weights and to get these things now is very expensive and not accessible. And so home gyms are very challenging, very costly, but like Ilana said, a resistant band, it's $1.99 online, and your own tools within your home, sitting up on a chair and moving around. And for people with arthritis, if you can't use the legs because of knee arthritis, well, move those arms, okay? So, we got to find ways to still be active. Short breaks, also people are sitting on those Zooms all day, getting up, walk around for 5 minutes and sit back down. Little short breaks makes a big difference. So we want a combination of aerobic exercise and resistance exercise, again, referring to the Diabetes Canada guidelines for some great ideas.
That's fantastic advice, and you're right. There isn't any excuse. Body weight exercises are great, and just moving and even doing I mean, I call my kids. They do laps around the kitchen table, and that's effectively their gym time. But I think the key part is about being able to keep moving and doing something. It doesn't have to be an hour worth of heavy duty, but just keeping moving is important to do. Switching gears completely, and we have a very limited time left, so I would love to touch on at the highest point, because this is another topic we could spend hours and hours on, which is research findings about type 2 diabetes. Is for each of you, if you could pick one sort of piece of research that is new and exciting for you. Talk a little bit about that and why that is. Why is that exciting? Because this is something. It's a chronic condition. There is no cure. It's not that you're not working towards one. I certainly understand that. But what's on the research horizon, Ilana, that really excites you?
Well, I think there's a couple. I mean, they're not just in research now, they're in practice, but there's just been an onslaught in the last 2 years of exciting publications in the fields of medications for diabetes that are also good for your heart and your kidney, and also help people lose weight and manage their blood pressure. And so to me, I think for the first time, we're now seeing diabetes type medications that are being used in patients who don't have diabetes, and they're having good outcomes in terms of hospitalizations for heart failure, progression to dialysis. So I think that's been really exciting, and it's allowed for a lot of interesting collaboration with our cardiology and nephrology colleagues. And I think we will continue to see more and more place. These medications are new, and so they are expensive. And so it's important for ongoing advocacy to get further coverage of these types of medications so that more people can take advantage of them. And it's always my chance to sort of, advocate or agitate for a national pharmacare type of policy, because a lot of people are not getting world-class or, first-rate diabetes care because they can't afford their medications. And then they wind up with more complications and costing the healthcare system more in the process. And so we need to invest up front, like you said, an ounce of prevention. But that's what I would say in my closing remarks.
I'd agree with that. I know we're tight on time, so I'm not going to add anything more, but to say that that's probably would be my number one response as well.
So it's fascinating to see actually the shifts and the changes in the course of the last decade relative to medications and support for those with type 2 diabetes. It is wonderful. Another sort of ounce of prevention is what I wear on my wrist, which is a MedicAlert ID. And I wanted to ask you both, physicians, pharmacists, paramedics, all first responders are familiar and know MedicAlert. It's a really important part of the continuum of care, because in times where people are in crisis and cannot communicate for themselves, this is a gateway. And it's not just what's on the back of the ID. This is a gateway to an entire database of information around patients that allow, whether it's you in your care or your colleagues in Emerge or your colleagues in the field. So I'd ask you, if you were talking about MedicAlert from the perspective of prevention, because it is a prevention tool, why would you, Jeremy, and why would you, Ilana, recommend MedicAlert to your patients? I'm curious.
Yeah, so Leslie, I mean, I definitely do recommend MedicAlert for certain individuals with diabetes, and probably the ones I would focus on most are on those who are on insulin, but really any diabetes agent that can cause hypoglycemia, meaning sugars generally under 4, like the sulfonylureas, the glycoside diamicron. But typically people who are on insulin in particular are at higher risk of hypoglycemia, and that's the point where if their hypoglycemia should get out of control and they can't help themselves, that could lead to a severe hypoglycemia where they need third-party assistance by a family member, friend, a loved one, or a person on the street. And I think especially with isolation and so forth, it's really a call to action for people who are at risk for severe reactions from their diabetes to obtain a medical alert ID bracelet. And as you said, it's not simply that, but it's the whole gateway to more information. And more information leads to faster reaction times to help people and can save lives. We have that clear data. And I think we talked a lot today about the aspect of teamwork in diabetes. I don't think it's simply the physician that needs to be recommending medical alert. This is something that the patient should bring forward, family members should bring forward, dietitians, nurses, pharmacists, social workers, physicians, and pretty much everybody who is seeing a person with diabetes needs to be thinking about preventative medicine. We use winter tires to prevent, God forbid, something should happen. No one wants to rely upon medical alert to, God forbid, that there should be such a reaction should happen. But if you need it, boy, aren't you glad you had those winter tires on? And so it's the same idea with medical alert. And I just, on a personal note, want to thank you, Leslie, and your whole medical alert team for all that you've done for patients and all the lives that you've saved.
Well, thank you so much, Jeremy. And Ilana, I hope and know that you would say the same thing about MedicAlert and your patients. We are celebrating 60 years this year. That's how long we have been around in Canada. And it's exciting to be able to say that we have helped many of those living with diabetes to get the information in the hands of first responders and the healthcare community in a timely manner to help when things do escalate out of control and that third-party help is required. So on behalf of us at MedicAlert, I'd like to thank both Dr. Jeremy Gilbert and Ilana Halperin for joining us today from their offices at Sunnybrook Health Sciences here in Toronto. We have a national audience today. It's been fantastic. I would also like to, again, to thank our friends at Diabetes Canada who do tremendous work to be able to support all of those who are managing diabetes and living with diabetes and those who are caring for those individuals with diabetes. I hope you've enjoyed the presentation today. I learned a ton. Thank you very much. And I hope you have as well. And we hope you will join us next time for our next Health Hour Live topic. And in the meantime, if you want to share this particular webinar with your friends and family, the recording will be in your inbox next week. Or later this week, pardon me, later this week. So thank you so much.
Thanks so much, Leslie. It was fun.
We'll talk again soon, I hope. Take care.
Bye-bye.
Bye-bye.